Ankle arthritis. The ankle joint is a modified hinge joint. It's highly congruent. And when we're walking, certainly greater than 1.25 times our body weight is going through this. However, when we're exercising, an excessive amount of force will go through the ankle joint with up to 4 to 7 times normal body weight. Now, the joint forces typically are distributed through the talar dome of up to 90% of weight through here, medial malleolus up to 20%, and the fibula then less than 15% normally. When we're looking at the ankle joint, we need to also look at the adjacent joints, the Chopart joint and subtalar joint. The subtalar joint functions like a mitred hinge. It's a rotation of segments in opposite directions, and it has simultaneous motion in all three cardinal planes of motion. The ankle joint itself, its primary motion, is 70 degrees of dorsiplantar flexion of the foot and ankle. Most of that motion is in plantar flexion with 50 degrees and 20 degrees of dorsiflexion, and it has really minimal inversion and eversion under normal circumstances. Now, unlike the hip and the knee, most arthritis in the ankle is post-traumatic in nature. And this is either from a inversion injury or ankle sprain or from an ankle fracture, where there's direct chondrocyte injury. It can also result from abnormal weight-bearing stresses, from articular incongruency, joint malalignment, and long-term ligamentous instability. Other causes of arthritis include inflammatory, primary osteoarthritis, infections, neuropathic, congenital, development, and hematological. The inflammatory conditions are the usual laundry list of inflammatory conditions that affect any joint. Rheumatoid arthritis is unusual in that the ankle joint itself is usually affected in late stage, and the surrounding joints usually are predisposing the ankle to ultimate malalignment. Crystal arthropathies, including gout and pseudogout, are also to be considered. And again, these are most common in the first MTP joint and show the pathognomonic signs of destructive arthropathy. Occasionally asked questions, including Reiter's and psoriatic and Angst-Bond, are asked, but these are uncommon. Other causes of destruction of the joint include infection, neuropathy, and neurological causes, as well as synovial abnormalities, including PVNS and synovial chondromatosis. Now, for the purposes of this talk, we'll be talking primarily about classification of post-traumatic osteoarthritis, and this is Takakura's classification, and this would be important to remember. Conservative treatments are typically asked in any board examination, and these include activity modification, non-steroidal anti-inflammatories. Steroid injections are not contraindicated, and in fact they may be chondroprotective in small doses and infrequently used to reduce inflammation. HA injections have been found to be beneficial in some studies, but less beneficial in others, and therefore their role is controversial. Rocker bottom shoe wear is used, as are Arizona-type gauntlet braces, and these have some symptomatic function and therefore will be asked in the exam. Surgical treatment options include arthroscopic debridement, realignment osteotomies, ankle arthrodesis, distraction ankle arthroplasty, and total ankle joint replacement, as well as allograft replacement. We'll go through these fairly quickly. Arthroscopic debridement is really reserved for just anterior impingement, or indeed rarely posterior impingement, to restore motion in early stage disease. Once these osteophytes are removed, there is a almost 80% chance of recurrence within 5 years. Realignment osteotomies, or supramedial malleolar osteotomies, are reserved for Takakura grade 2 and 3A varus alignment. They have less satisfactory outcomes in valgus alignment. Distraction ankle arthroplasty is used in some selective centers, popularized originally by Van Roermond in Europe, and now used in several centers in the United States. A recent study shows that there's greater than 70% satisfaction in these procedures, particularly in a young population with a congruent joint. These are rarely performed, and although a viable option, will probably not be a principal question on your board exam. Practice patterns in the United States over the last 10 years have indicated that while ankle arthrodesis is the benchmark of treatment for this pathology, there is an increased number of arthroplasty procedures being performed. Currently, we are now on the fourth generation of ankle arthroplasty, and certainly these are improving with each generation. And as they're improving, so too is the frequency of use. But for now, ankle arthrodesis remains the benchmark. The outcomes of ankle arthrodesis are encouraging. Pain relief in up to 80 to 100% of patients. And while pain relief is globally identified as while pain relief is ubiquitous among studies, also the complications of long-term ankle arthrodesis are also seen, with a significant number of patients having subtalar and Chopard joint arthritis. Overall, most patients are satisfied with ankle arthrodesis. When we look at recent studies of ankle arthrodesis versus arthroplasty, a study by Salzman has shown that the overall satisfaction is somewhat similar. The ABOS scores are similar, but as you would expect, the functional outcomes of patients with arthroplasty are better than those with ankle fusion. There are more operations, however, and complications with total ankle arthroplasty. Dioro and colleagues performed a meta-analysis of 25 studies involving over 2,000 total ankle replacements, and they showed that there was equal pain, relief, and improved function in both groups. However, most patients who had a arthroplasty required a second procedure. More recent studies by Tim Daniels and his group showed that there was no difference in ankle power or temporal gait parameters between the two groups, and neither ankle arthroplasty nor arthrodesis replicated normal ankle motion or gait. Brodsky found also that neither group functioned as well as the normal control subject. Neither group was superior in any parameter of gait at year 1. The indications, therefore, for an ankle arthrodesis are failed non-operative treatment, moderate to severe arthritis, a failed ankle arthroplasty, septic arthritis, and neuromuscular deformity and weakness, and recurrent ligamentous instability. Technique goals are the same as they would be in any surgery: to restore proper mechanical alignment, minimize height loss, minimize soft tissue stripping, and rigid compression and fixation. The position of the ankle is important. It should be a neutral dorsiplantar flexion, 5 degrees of valgus, and 5 degrees external rotation. Fixation can be any of the typical implants that we use: screws, plates, rods, K-wires, etc. There are concerns with ankle arthrodesis, and the non-union rate is somewhat higher than you would anticipate, with up to 40% in some studies. Malunion has also been seen, and gain changes with increased energy expenditure and loss of motion, with transfer stresses and arthritic changes to compensatory joints. At 8 years, 50% of the subtalar or talar-navicular joint will exhibit some signs of arthritic change, and that will increase to almost 100% at 20 years follow-up. The reasons for non-union in this are multifactorial, and again, these would be typical for any arthrodesis non-union, with advancing age, poor blood supply, malalignment, and so forth. And this is a laundry list of these reasons for non-union. There's been a trend recently for arthroscopic debridement and fusion, And the disadvantages of an open versus an arthroscopic approach include extensive soft tissue dissection, infection, wound healing problems, delayed weight bearing, and slow recovery. The advantages of arthroscopic, by comparison, are reduced morbidity, minimized soft tissue damage, and reduced blood loss, more rapid fusion rates, more rapid rehab, and decreased non-union rates. So the arthroscopic indications are failure of greater than 6 months conservative therapy, no active infection, minimal bone defects, and it should be able to be corrected in the coronal plane, and moderate deformity corrected to neutral under fluoroscopic realignment. Contraindications to arthroscopic arthrodesis are an irreducible varus or valgus deformity, significant bone loss, a previous attempt at fusion and broad-based ABN, or indeed a history of septic arthritis. Now, the procedure for arthroscopic debridement is the same as standard, non-invasive distraction of the joint, remove anterior osteophytes initially to gain access to the joint, and debride the talus and then the tibial plafond, and debride the gutters. And once we're down to bleeding subchondral bone, then we can fix this with cannulated screws. The addition of bone graft, either autologous or indeed from any bone graft substitute, is somewhat concerning at this point, as there does not seem to be definitive evidence that any bone graft substitute will improve will improve the outcomes in terms of union rates in ankle arthrodesis. The results of arthroscopic arthrodesis are very satisfactory, and you can see that most patients, over 90%, will do well. When we compare arthroscopic versus open procedure, we can see that there are better AFAS scores at 1 and 2 years in the arthroscopic assisted group, and shorter hospital stays. There are higher complications, as you would expect, in the open group, and once again, better AFOS scores in those treated with the arthroscopic assisted. In a meta-analysis recently in the Journal of Clinical Orthopedic Trauma, over 200 ankles were identified. Lower fusion rates, longer lengths of stay, longer tourniquet time in the open group. They did, however, identify that they had a similar infection rate, complication rate, and OR time, and the outcomes were unable to identify. So for the purpose of the board exams, it does appear that the arthroscopic assisted group has a higher fusion rate and lower hospital times than the open group. Hope this helps you in passing your board exams. Good luck.